Okay, hello everyone, and welcome to the ASPPH Presents webinar, Mobilizing Civic Engagement to Advance Community Health. I'm Tim Leshin. I'm the Chief External Relations and Advocacy Officer here at the Association of Schools and Programs of Public Health. Really happy to have you here. This is going to be a great discussion. For those of you who are new to our webinar series, ASPPH is the voice of academic public health, representing more than 150 schools and programs across the country and the globe. We deeply are committed to advancing health equity through policy, education, and community engagement. In fact, I was just at a meeting at University of California, San Diego called Building Next Gen Leaders, and it was all about civic engagement, especially on college campuses and creating forums for civil dialogue. And I got very inspired by that, so I'm really excited to have this conversation today. Um, our advocacy team here at ASPPH works every day to amplify the voices of schools and programs of public health on Capitol Hill, and our members in their communities nationwide. And through, excuse me, through our commitment to dismantling structural racism, ASPPH continues to champion evidence-based policy, civic participation, and social justice as essential to public health. Today, our conversation on civic engagement reflects that mission, bringing together partners across academia, philanthropy, and community leadership to explore how civic participation strengthens democracy, advances equity, and improves health outcomes. Maybe that's the most important thing. Before we begin, just a few quick notes of logistics. This session is being recorded, and the recording will be made available to all the registrants afterwards. Please use the Q&A feature to submit your questions. We'll reserve time at the end to address those questions. And today we'll explore how civic engagement acts as a powerful catalyst for advancing health equity and shaping responsive public policy. We'll hear about how community-driven participation is transforming public health efforts in Kansas, Missouri region, and beyond. Our panelists will share how civic engagement drives equitable public health policy and the role of academic and philanthropic institutions in fostering democratic participation. So I'm really delighted to introduce our panelists, and then we will have them jump right in. So our first panelist will be McLean Bryant Macklin, who is the Chief Policy and Impact Officer at the Health Forward Foundation and a member of the Network of Public Health Law National Advisory Board. She leads civic engagement strategies rooted in equity, community, and empowerment, and bridging philanthropy, policy, and grassroots mobilization. We're next going to hear from Elizabeth Baha, who's the professor and vice chair of the Population Health at the University of Kansas School of Medicine in Wichita. Dr. Brings deep experience in community health assessments and advocacy with a focus on how educational institutions can strengthen civic engagement strategies and advance local leadership. And then we will hear from Dr. Cynthia Pacheco, who is assistant professor at the University of Kansas Medical Center in Kansas City. Dr. Pacheco focuses on health equity and civic empowerment through community-based research with Indigenous and Latino populations, using her expertise in law and population health to explore how academic institutions can advance engagement through policy, education, and partnership. So thank you all so much for joining us. To start off, I'd like to invite each of you to share your opening remarks, and we'll start with McLean first, please.
Good day, everyone. I'm glad to go first and hopefully can take some of the pressure off of some of the other panelists by doing so. I am not an academic, and I'm here to share the perspective of a foundation that is deeply engaged in advocacy and grateful for the opportunity to dialogue with some folks that I don't ordinarily have the opportunity to interact with. So I want to just show my appreciation. Next slide, please. So I assume most folks are unfamiliar with who we are and what we do. So I'll just start a bit with some background. So Health Forward Foundation is a public health conversion foundation. I assume folks in this space are aware of what that means. We are endowed through the proceeds of the sale of a nonprofit hospital to a for-profit, and our service area is dictated by the places where that nonprofit hospital had a footprint. We're also organized as a 501(c)(3) organization, which provides us with some flexibility, but not complete flexibility to engage in advocacy. Next slide, please. And so our purpose is that every day we work to support and build inclusive, powerful, and healthy communities characterized by racial equity and economically just systems. Our mission is that we aim to achieve health equity and secure a fair and just region through leadership, advocacy, and resources. Again, that service area where we occupy space and fund is in both Kansas and Missouri, 3 counties roughly on either side, and includes rural, suburban, and urban areas. Next slide, please. All of the work that we do is guided by our purpose plan, in which we focus our work in four key areas: platform, people, power, and place. We advocate and support the advocacy of other nonprofits on issues related to all four of these strategies, but I wanted to note that we have a distinct strategy around power, where we centralize supporting and uplifting the power that exists in community and amongst nonprofits. And key to that strategy is our support of civic engagement. And so we aim to support advocacy along the entirety of the spectrum. So from litigation to legislation to really the gamut. The only thing we cannot do is to participate in partisan or electoral politics because of that 501(c)(3) designation. Next slide, please. So I mentioned some of this previously. Why do we do advocacy? It's very much related to our mission statement. We employ 3 key levers, which are resources and our different funding opportunities, which we do through grants somewhat, but have really moved in the direction of primarily funding through gifts, which are unrestricted core operating support. Also through our leadership, using our voice and power in the spaces that we occupy, from civic to grass tops to grassroots, and among other philanthropic organizations, to encourage other foundations and others that hold power, disproportionately so, to use their voices and power for the greater good. And then we also use the lever of advocacy and recognize that without any of these 3, we won't be able to reach our North Star, which is really systems change and longstanding change of the communities that we support. So the different ways that we do advocacy, again, I don't think that there's a way that we don't do advocacy except for not engaging in partisan politics. We lobby and take the H election, for those that are familiar with that sort of ability under the IRS code to lobby up to a percentage of your budget. And so that provides us with flexibility not only to have retained lobbyists and for our staff to lobby, but also for us to support the advocacy of our funded partners, which we do in both C3 and C4 organizations. Again, though, with the caveat that for C4s, our funding cannot be used to support any partisan or electoral activity. We also fund litigation, which I hope everybody includes in their definition of advocacy. We often find, that things may start in the legislature or start by ballot initiative, but they are soon followed by litigation to enforce or fund those initiatives. And so we like to stay with an issue through its life cycle. Um, Next slide, please. So I wanted to provide some examples of our advocacy to really help to contextualize how we show up in the space and where there might be opportunities for other foundations to occupy space as well. We are, I think, best known for our support of Medicaid expansion in Missouri. Missouri is somewhat unique in that it's one of 24 states where citizens can pass laws through a ballot initiative and referendum. And so that is a key lever that community uses to enact laws where the legislature has proven unwilling to do so. And so, after many attempts to expand Medicaid through legislation prior to 2020, our foundation really provided most of the funding for the campaign, as well as having organized grassroots and grasstops leaders from across many sectors, chambers, healthcare providers, and payers, to individuals to ensure that there was the groundswell needed not only for the signature gathering that is necessary to put something on the ballot, but also to educate voters and to ensure that voters turned out to vote in support of Medicaid expansion. That involved a lot of research that was costly. It involved a lot of opinion pieces and paid and earned media that we supported our nonprofit partners and helped to elevate their voices and lived experiences and stories to help to really add color to why Medicaid expansion was important to the state. And so that is just one example of how not only did we lend, dollars to an effort, but really lent the entirety of ourselves as an organization to ensuring that Medicaid was expanded in Missouri. Next slide, please. And then the most recent example would be in the anti-redistricting effort currently underway in Missouri. We are not unique in efforts to redraw congressional district maps, but we are unique in the fact that we've got an opportunity to overturn those maps through the ballot initiative effort. And so we have used some of our dollars to support the C4 effort to collect those signatures, and then our positioning ourselves to support the campaign as well. And so just wanted to give a little flavor to what we do and how we do it, and I'm happy to answer any questions that follow. Thank you.
Great, McLean. Thank you so much for giving those specific examples. Now we're going to turn to Dr. Abla. I think keep saying it wrong. I apologize.
You nailed it. You nailed it.
Okay.
Thank you.
All right, good. Go ahead.
Thank you so much. Tim, really appreciate the opportunity to be here and to present with these esteemed colleagues of mine, and really excited to be able to be a transition between McLean and Dr. Pacheco, because this is really a perfect presentation for that. If you wouldn't mind, go to the next slide and the next slide after that. Thank you. So I'm just going to tee this up in thinking about community health broadly, thinking about all the components that contribute to what a community's health might include. For instance, social determinants of health and place-based health, also thinking about, obviously, the key here that we're talking about today is health equity, but also participatory approaches and how community groups and academics and foundations and others can work together to be able to build a model that allows for community health to grow. If you don't mind, go to the next slide, please. So we know that there are a couple of things that are really special about civic participation in the academic world, and one is that it's a protective factor and it's also a driver of change when it comes to health. That when people feel like they are engaged and they are engaging in a process, in work that is meaningful to them, then there are some really positive aspects to that. If you don't mind, go to the next slide. you'll see that according to social capital theory, there are three components that occur as a part of social capital theory. One is the creation and development of social networks, and shared norms are then occurring, and this results also in fostered trust. This is really critical to the presentations that I'm going to give, and I know that Dr. Pacheco is about to give as well. So these components then facilitate or can facilitate collective action, which then can be associated with improved health outcomes. So that's really the cornerstone for this, because not only is it important that people are engaged and are feeling like they are heard, but they are also gaining their own social networks. They're also gaining their own self-efficacy in and improving their health. So if you wouldn't mind, go to the next slide, please. So I'm going to talk briefly about a groundwater contamination project that we call the 29th and Grove project, because that's where most of the contamination was identified. If you wouldn't mind, go to the next slide. You can see that there is a very large plume that was identified. That was actually identified in 1994. You'll see from the timeline, there were a couple of years that scooted on by, and then Kansas Department of Health and Environment confirmed the contamination in 99. The first feasibility study for cleanup options occurred in 2008. And then some remedial measures began in 2009, and the second feasibility study with a different group in 2020. And many of the residents learned of the contamination in 2022. I'll say most of the residents learned about it in 2022. There were presentations that had been given prior to in around 1999 when KDHE had identified and confirmed that the contamination was present. But there are some real issues from the community's perspective that they felt like they were not involved in this process and not aware of what had occurred. Next slide, please. So the communications that occurred were very sparse and fragmented, and very technical language was used. And so how did that go? Not tremendously well. So if you go to the next slide, what I think one of the three things that really occurred as a result of this, their health concerns became really top of mind in 2022 and 2023, when more of the residents were notified and aware of the process. The properties in that area, in that neighborhood, the 20th and Grove plume, had devalued pretty significantly. And this is really important because this is an area that has been historically marginalized and underserved for decades. And so now they have yet another thing that has been a problem for their community. And most importantly, potentially, residents are feeling devalued. So this has a huge impact on health and engagement often in civic processes. If you go to the next slide, please. So they spoke up. And I will say that there have been many contamination plumes that have been identified in our area. And one of the reasons that I've been involved in this is because I have been engaged in other contamination plume explorations and investigations. And when I see that as a result of the community engaging in this process and communicating their frustration with this, the Kansas legislature then in 2024 decided to make dollars available for the very first time with any type of contamination like this. So as a result, a number of people got very engaged in starting to think about how the funds would be used. Now, I will say that the legislature had a rather narrow view of how the funds would be spent. And these various representatives, including community health leaders, and you'll see Kansas Health Foundation that I'm going to flag a little bit more, they started having these conversations about how do we really want these funds to be spent. All told, with all of the funds that were going to be raised locally, and funds that were going to be provided by the legislature is about 3.5 million, and they wanted it to be spent within a year. And that's just not realistic when we're talking about the need that is much longer term ongoing. So these groups got together and started having some pretty serious conversations. If you go to the next slide, please. Thank you. So Kansas Health Foundation really stepped forward. They have created a really important agenda around becoming the healthiest state in the nation and working to eliminate health disparities as two of their three goals. They hired KU, they hired us to start coordinating efforts. They worked very quickly on a match. Very quickly, they were able to raise more than $1 million in a couple of weeks to help make this occur. We all worked with Sedgwick County, which is the county that we are in here in Wichita, also the city of Wichita, and a number of private partners as well. The funds then went to a grant opportunity that Kansas Health Foundation is offering instead of providing funds to individual tests where 10 people might get tested 10 times. We wanted to really increase the capacity of organizations in the community to be able to expand their capacity to be able to do these tests long term. So purchasing ultrasound machines and whatnot. And then we recruited a community advisory group. If you go to the next slide. So just a couple of weeks, the grantees were identified. Then in, I believe, next week, we're planning on doing a press conference with multiple partners, all these folks who've been working on this together. We are planning on talking about who these grantees are and what kind of work that we're going to be doing over the next year and 3 months. And we now are going to be providing supports for grantees regarding testing and also communications, because communications have been so disparate and really need coordination. If you wouldn't mind, go to the next slide. And this is my last slide before I turn to Dr. Pacheco, and that is the intended outcomes of this work. We really are wanting to establish a shared purpose that is extremely important, that we are all working together toward the same goal. We want to improve trust and establish that and build on that so that we can continue doing work around equity in the 29th and Grove neighborhood and extend beyond that as well. And then strengthen community cohesion within the community. There are really strong community leaders, and if there are ways that we can build trust within the community as well, that's really where we're wanting to go. And then to obviously improve the health outcomes for this community. So I will take questions after, and very excited to hear Dr. Pacheco's talk as well. Thank you.
Thanks so much, Elizabeth. It's a great example of the work you're doing here. So yes, we will turn to Christina Pacheco next for her remarks. Go right ahead.
Thank you. And thank you so much for the invitation to join this conversation with Doctors Bryant Macklin and Abla. My work centers on advancing health equity through community-led and community-owned approaches, particularly among Indigenous, Latino, and rural populations. For me, civic engagement is the heartbeat of public health. It's how communities move from being research subjects to co-authors of the systems that shape their well-being. In both my academic and community work, I've seen how civic engagement, whether a small town coalition, a tribal council, or a county health equity team, can transform not just programs, but also power structures. Next slide. So real sustainable change does not happen in isolation. It happens with communities, not just for or to them. And I am incredibly excited to introduce you to a remarkable example of just that. And that is the COPE project, which I have had the honor of working on with Dr. Alba. So this is the Communities Organizing to Promote Equity project. And I was tasked with directing this project for 3.5 years. It was born out of the urgency of the COVID-19 pandemic and the disparities that it exposed and widened. It grew into something far greater. It became a living model of community-driven health equity in action. Through local health equity action teams, COPE mobilized 20 counties, empowering local residents, hiring community health workers, and tailoring strategies to the realities of each community we served. We built trust, not transactions. We fostered autonomy, not dependence. And most importantly, we demonstrated that when community members lead, solutions are not only more effective, but they're sustainable. COPE shows that success lies in co-creation. By partnering directly with residents, communities accessed or addressed vaccine hesitancy. They improved access to health and social services and created a resilient, informed public health ecosystem. Next slide. So as I mentioned, the magic of COPE really lives in its local health equity action teams, or what we called LHEATs. And what makes these teams extraordinary is that they're not just comprised of experts. Instead, they're made up of neighbors. They bring together three essential voices: community stakeholders who live the realities of the unmet needs every day and bring invaluable lived experience to the table; community health workers who help implement the strategies and stay deeply connected to the people they're serving; and organizational leaders who understood the local landscape of services and partnerships. They also knew how to open doors. Through the COPE project, each team received a budget of $50,000 to address priorities they collectively identified in their communities. Next slide. And you might have to forward a couple times. I'm sorry. There you go. Perfect. I want to share that we had people embedded within communities across the state, and the highlighted counties are the counties that were COPE counties. And this really shows that COPE was not an abstract concept. Rather, it was deeply local and deeply personal. Next slide. So I'll show a couple different examples of strategies that the different teams came up with and kind of the impact that they had. But this is one that I really want to highlight. And Dr. Abla is actually leading a paper on this that is soon to come out in the American Journal of Public Health. So one story that really captures the spirit of COPE is Laundry Love. Laundry Love is a national neighboring movement that encourages collaboration among residents, organizations, and laundromats to reduce barriers to clean laundry. Through coordination with national organizations, sites receive various resources for chapter startup. Through COPE, we engaged laundromats in 10 different counties, and were able to offer more than 17,000 loads of laundry across the state. Not only did this allow for residents to have clean clothes, it also opened the door for our community health workers and our local health equity action teams to meet with residents that may have more distrust when trying to approach social services. So they were able to get them enrolled in different social services at the laundromat. In Wyandotte County, they were offering this in 2 locations on a monthly basis. And these initiatives are ongoing. I believe here in Bourbon County, where I'm at right now, they have an event going on tomorrow. So this is something that has been sustained beyond the project. They have gotten communities, organizations, and community members to invest in this project because they've seen the impact it has had. We've had individuals and communities get jobs from these events, get enrolled in different services, a whole host of different things. So this was really just an opportunity to open that door to reach our neighbors. Next slide. So the results from this project truly speak for themselves. Across the project in 3.5 years, we had 753 people serve on these local health equity action teams. We engaged over 2,700 partner organizations, and our LHEATs initiated 384 different activities and strategies to address health equity across Kansas. Our community health workers engaged over 11,500 individuals to offer direct services, and we served and reached over 235,000 Kansans. the vast majority of them were rural residents. Next slide. Finally, I want you to see just how comprehensive COPE's reach has been. So across 20 counties, they tackled a wide range of health equity priorities. Dignity initiatives would include Our Laundry Love, but in Southeast Kansas, we now have 4 communities with public transportation and when they've never had public transportation before. And these services are offered completely free of charge. And most of that was done through partnerships. We offered a little bit of seed money, and communities came together, saw that this was possible, and decided to invest in it themselves. So if you will skip forward one more slide. One more, sorry. So I just want to close with our communities and their passion really is the fuel that powers me through the long nights and the hard days that I know that we encounter in public health quite frequently more recently. And so I encourage individuals to let our community's passion and strength ground you when you start to feel the winds of doubt blow strong. Because when the dust settles, and it will, the world will look to us, public health, and we will not only rise to the moment, but we will build something better as we always have. So thank you.
Thank you, Christina. And thank you all for your powerful opening remarks, really insightful. Each of you has touched on how civic engagement serves as a lever for systematic change, whether through policy reform, community organizations, or academic partnership. So that was great to hear. And I think now we're going to move to some questions. I'll ask a few questions of each of you, and then there's some broader questions for the group, and then there are some questions coming through in the Q&A as well we'll get to. So we'll go back to the same order. McLean, I'm going to start with you. And you've said that civic engagement is the cornerstone of equity. So how does Health Forward Foundation operationalize that? You've talked a little bit about this already, but can you talk a little bit about the idea of the grant making and partnership and give a little bit more examples about that?
Yeah, happy to. So I'll start with we all have power and voice and should all have agency in our democracy. But that's not always the case in either how policymaking is approached or the intended or unintended impacts of policy. And so what we aim to do, both by lending our voice with understanding that philanthropy holds power and has contributed to existing power structures and inequities, but also by making direct investments in nonprofits and individuals to engage directly in advocacy themselves. And so, we offer supports in advocacy trainings. We contract directly with the Alliance for Justice and Boulder Advocacy to ensure that nonprofits are positioned to engage in advocacy, within the rules and constraints on nonprofits in doing so, to really encourage and provide the safety and security, in addition to the encouragement for nonprofits to do so. We also provide, capacity building funding, knowing that many nonprofits are thinly staffed and may have 1 to 3 people that are wearing multiple hats. And so additional FTEs or part-time employees help to ensure that they're able to keep the lights on and advance their programmatic work while also adding advocacy to their scope. And we know how important allies are in advocacy. And so not only our own allyship, but encouraging through our leadership and through our encouragement and through our lifting up of the stories and experiences and the data that might otherwise be unrepresented at a table, and speaking on behalf of or inviting into spaces some of these nonprofit leaders and individuals, just to help ensure that folks have the opportunity, as well as folks are heard in their advocacy. And so we really aspire to show up in any way that we can within the confines of our own, 990 lobbying caps, to support others in advocacy as well as to advocate ourselves.
Thanks so much, McLean. It occurs to me that your organization is somewhat unique in terms of being a philanthropy that supports advocacy. Do you have a sense of their, because I'm thinking about people all over the country who may want to be able to tap into that kind of philanthropy. Do you have a sense if there's other organizations people could consider talking with?
There are others nationally that lean into advocacy. I would say, to the extent that we do. And our challenge in the Kansas City region is that there are few that lean as far as we do. And so, and both sides of the state line in Kansas City and Missouri. Private foundations are just much more constricted and confined, and so aren't really a viable source for funding in this space. But public foundations, as 501c3 nonprofits, can. Many elect to, but they, through their bylaws or through, other policy and practice, have elected not to, because just different risk profiles, I would say, amongst their boards, or appetites amongst their boards. And likely because of some element of, self-preservation, and wanting to ensure that they continue for however long, including up into perpetuity, can stay in existence to support nonprofits through their grant making. And it's a particularly scary time for nonprofits and foundations to engage in this work. And so I say all that with understanding. We, though, have had advocacy as a part of our mission since near inception. And so we are leaning in because we feel that the time, evermore is now, to show up, strongly and unafraid. But we've done our own, risk assessments, and we are very careful with our own, accounting and auditing to ensure that we are coloring within the lines. But while doing so, hoping to, paint a beautiful picture of progress for nonprofits. Did I answer your question? Sometimes I get lost in my flowery words.
You did a great job. Thank you so
Okay.
much. Elizabeth, I'm going to turn to you now. Sort of a two-part question. One is, what do you think the best practices are in this space, and how can institutions that are training the next generation of public health leaders do a better job of training them in this space?
Those are fantastic questions. Thank you. I would say, let's start with the idea of evidence-based practice. I'm based at a medical school and in Wichita, Kansas. And I think that we drill into students, in medical students as well as master public health students and others, the importance of evidence-based. And why evidence? Why are we talking about this accumulation of research? Because we've learned from it, and let's not make mistakes that we can prevent, right? So I think we have relied on evidence to guide us, really meaning any type of research to guide us. I think there is another world where communities are really moving forward at maybe a slower pace, just in that there is not as much money that is allocated toward community-based research, that allows for practice-based interventions to occur and learning from those lessons, and realizing that there are different environments that very much influence how some of these practices may land, within a community. So when it comes to thinking about how you balance that out, I think it's really challenging. But I don't think you can really do wrong if you are listening to the community. And depending on the type of model and the type of questions and where the problem originated and who is engaged in the process, it can be a really wide spectrum of where engagement could look like community members are participating, all the way to community members are leading and moving this forward, and maybe academics are joining in alliance and in support, maybe through evaluation or resources, or whatever they are needing. So I think a really critical point in terms of your second question of how do we get folks engaged? How do they start? And that's really to begin. And I know that's a silly response, but it's absolutely true. If there is a priority that is a huge health equity priority in your community or another community, go talk to people who are engaged in that process. If you don't know what the priorities are, you're not hearing from community members, or you are part of a community that is identifying a problem and you're not doing anything about it. It's a great time to just talk with other people, even friends, and find out, hey, what do you think about doing something, getting engaged? Who do we talk to, and start having some of those conversations? Because honestly, the only way that we can make progress is if we engage and if we try. And it is really frustrating, I know, especially in an environment where there's so much ambiguity and so much confusion, especially like with a government shutdown. How do you navigate some of these things? Academics can be helpful there, and can help navigate a bit of that process. And so I think really honestly just starting, and asking folks to get engaged and to start talking about getting even dialogue going, that can move all the way to very organized initiatives like what Dr. Pacheco was mentioning, with COPE, where they have local health equity action teams where the people are working together and thinking through these things as teams in communities, and intervening with various projects like Laundry Love. So I think it really is a spectrum, but as long as you're engaged with a community, you have that inclusiveness and that willingness to just explore. I think you really can't do a lot of harm that way. It's great to just get going.
Great. Thank you so much for expanding on that. And, it's so clear for a long time, higher ed and academia has done research on communities, and what we need is research with communities, with them, as you say, sometimes taking the lead on what the issue is that should be focused on. Christina, I was, really fascinated by what you were talking about in terms of your organization leading with Latino communities, and indigenous communities. And I'm wondering if there's some unique pieces, in that space. And I'd also be interested in if you could sort of explain a little bit more about how the laundry project, got started, because I think that's such a great concrete example.
Yeah, thank you. So to address your first question about kind of what does the work look like, and how does civic engagement maybe show up uniquely in different spaces, is that, it really does look different in different contexts. Um, but what often emerges, regardless of the population you're working with, is this notion of collective responsibility, storytelling, and trust, as opposed to necessarily formal structures. Um, In a lot of my work with Indigenous partners, civic engagement is more relational. Oftentimes it starts with ceremony, with reciprocity, and honoring our elders, those who came before us and who really laid the groundwork for what we are hoping to do. In Latino communities, the work often flows from faith-based leadership, mutual aid, and family networks. In rural communities, it's about neighbors helping neighbors, mobilizing through churches, schools, local fairs. There may not be a health department around the corner. And so you have to kind of rely on maybe non-traditional partners when you're thinking about health equity and civic engagement. But across all of these contexts, it's really important to know that engagement is not new. It's a part of who people already are. And our role as public health and academics is really to create conditions that value and elevate the local wisdom within civic systems that are too often overlooked. One thing that Dr. Abla touched on is practice-based evidence. And I think that it's really important to note, and I really preach this in a lot of my work, particularly working with communities that have often been left out of evidence, is that there have been generations of people engaging in practices that, have worked. It just isn't in the evidence base that are, I guess, employers, our scientists really rely on, but that doesn't make it any less valuable. It doesn't make it any less credible. And I think that we really need to work in tandem with communities to learn from that practice, and to also, elevate those structures that are working that other communities can also learn from. Your second question around how did Laundry Love start? It really starts, so it's a national organization, so it started way before Kansas. But how did it start here in Kansas and spread? Is really that we had one individual on a local health equity action team in Barton County recognize that there was a need, that they were seeing individuals in their community who were struggling with hygiene. And we've heard stories all across Kansas from individuals who don't have access to running water in their homes, to individuals who, I mean, if you've ever gone to the laundromat, you can easily drop $30 to clean, just a few loads of laundry. And a lot of our families, that's a decision between paying a bill, feeding their family, or washing clothes, right? And so, it's a hard decision to make. And I think it's a decision that a lot of us maybe on this call have never had to make, fortunately. But a lot of our neighbors do. And so they did the work, the legwork. They found out that there was this entity called Laundry Love and that they could start up this chapter. And through COPE had some of the funds to really support that. We would get our communities, all 20 together, to talk about what they were doing, and it spread like wildfire. When they talked about this initiative, we had other communities say, hey, we've seen that in our community too. So Laundry Love, or aspects of it, have really spread, and our communities have used their context to really adapt that idea in different locations. In some of our communities, they don't have laundromats, so they can't rent out 4 hours of a laundromat and offer free laundry. So what they've done instead is they've purchased washers and dryers and put them in food pantries. So that way people can also access those at any point in time. In some of our other communities, they have gone through and provided quarters for some of our low-income housing that might have in-unit, or not in-unit, but in building laundry. So that way it's no longer a burden for folks to do that. So they're providing the quarters and the soap as opposed to, renting out and having folks go to a location that may or may not exist in their community. And so, yeah, we're really excited about it. It definitely opened the door for us to engage folks in other services, to get them signed up with community health workers or other social services. Because if they're struggling with laundry, more than likely they have other needs as well.
Yeah, just a very good concrete example of how to do something that's very practically helpful to the community, but also as someone who used a laundromat all through graduate school, you're a captive audience too. So it's a chance to really build community at the same time. So it's great. So we have a bunch of questions here. I want to get to the audience questions from I believe it's Dr. Trapani, but I'm sorry if I mispronounced the name. She's asking a lot of questions, but one is, what are the strategies that schools of public health can use in their with their local health departments to make civic engagement sustainable and equitable practices? And I think that's always a big challenge. Anyone, it's open to anyone to answer that question.
I'm happy to give it a start. I know with what Dr. Pacheco is just referring to with Laundry Love, for instance, what has made that sustainable is the initiative of getting civic engagement and community organizations and private foundation, or not private foundations, actually it is private foundations, all to contribute funds. And so they have then been able to they sponsor the wash or the washes of the Laundry Love events, those for that month. And then that has allowed for then the community to be sponsoring this work. And so it is ongoing in the Barton County and in many other counties in Kansas, that having that type of sustained infrastructure where there are community health workers, that really puts the infrastructure back on the need for our health departments to be able to continue this type of work. We really need different types of funding than what are currently available from an academic perspective. If we are wanting to do work like this, it is usually a short-term grant, at best 5 years. And when we're looking at real change that needs to occur in communities, we have real needs to make a real difference rather than something that Dr. Tripathi, I think, is referring to, that really does need to be more sustained. And so funding mechanisms really need to change in order to be able to have that longer term impact, in order to really make health equity a possibility. But yeah, I think the question's an excellent one, and I'll cede my time to others.
I wholeheartedly agree. And we've been looking for ways to get more bang for our buck. And just an example, like we recognize that most health departments don't have an attorney that specializes in public health. They at best have, a city or county attorney that is a generalist. And so we worked, what is it, unhumble plug, with the Network for Public Health Law, to contract with them to provide legal services to health departments that's a bit more specialized. In Kansas and Missouri, there have been concerted efforts since the pandemic to take power back from the health departments. And so they were particularly vulnerable without, representation that, not only is specialized, but shows up more like outside counsel than inside counsel, because I would argue as a lawyer, your inside counsel tends to be a bit more risk adverse, and your outside counsel tends to be less so. And so just wanting to ensure that they were supported, because they need a variety of different supports in the advocacy realm in that way.
Fantastic. Thanks so much. So I think we've sort of addressed most of those questions that are in the chat in varying ways. But what I want to figure out is how can you all inspire our schools and programs to take this approach? What are some things that, people who are tuning in here can take away from this that they could use in their own communities to make sure that they're engaging in an appropriate and effective way that shows impact on public health?
I can start us out. It's wildly rewarding. I think often academics are so far out of the application and the practice of the rest of the world, that there's such a wide disconnect between practice and academics that I think it can often feel like there is not a lot of meaning in the work that we do when it's in a lab that has great significance on a paper, but maybe not to a bucket list or what we want to accomplish in the world. And this is that, at least for me. I think being able to see that there's a real need, and then to be able to identify what resources are needed in order to start addressing that need and figure out who can be at the table, who else can be at the table, how do we largen the table and enlarge the table and think about the work that we do in different ways than what we've tried before, so that we can be successful.
Yeah, I'll second that. And I'll key in on just the importance of research and data into advocacy, and research and data that's colored by lived experience and qualitative data are just as, if not more, important. Data disaggregated by race, ethnicity, language, particularly in public health, is so important. And while there are different health departments or researchers that may disaggregate in some way, the uniformity of that disaggregation so that the information can be compiled and analyzed in usable ways so that resources can be deployed to the areas and communities that need them most, is an opportunity area for academia to show up in this space as well.
Great. I'm very conscious of the time. Christina, do you have a quick comment?
Yeah, I would say I think we've moved away from like face-to-face conversations as we're giving a virtual webinar right now. A lot of my classes are taught online. And so one of my favorite things to do with students as well as other academics is to get them out into community talking to people. I think it's so easy for us to disconnect and lose focus on the humanity of individuals when we're behind a screen. And it's really, as Dr. Abla said, it's fun, right? But you also get to see maybe where people are forming their opinions and their perspectives when you're in the same context that they live in every day. And so I think that's really important, and would be kind of my final thought, is to make sure that folks are getting out into the communities that they're serving and trying to work with and for.
Wonderful. I really want to thank each of you for really insightful remarks and a great discussion that I think can be really valuable for our members and others who want to engage in these kinds of civic engagements at their local level. So on behalf of ASPPH, I want to thank you. I also want to let you know that we are going to have another webinar coming up um, on November 19th. That's on advocacy as well. We're going to be looking at the advocacy landscape once again for public health and trying to give you all updates on that. But really want to thank this panel and feel like you've empowered us to follow your lead and maybe take on some really big challenges in local communities. So thank you so much.
Thank you.
Thank you.
Great job, everyone. Really appreciate you taking the time to do that. And, we will have the recording, and we'll let you know.